Hi, everyone, and welcome to another PRISMS webinar, The History of Smith-Magenis Syndrome with Ann Smith. I'm Allison Stefanock, and I'm a board member, and I'm also PRISMS Education Chair. This webinar is brought to you by PRISMS. PRISMS is an acronym for Parents and Researchers Interested in Smith-Magenis Syndrome. PRISMS, in addition to funding research and increasing awareness of Smith-Magenis Syndrome, PRISMS is dedicated to providing support and information to families of persons with Smith-Magenis Syndrome. The goal of this webinar series is to share information with the SMS community in an easily accessible way directly from the experts who are working in the field. A recording of this webinar, as well as all future webinars and past recordings, can be found on the PRISMS website under the Education tab. If at any time you have questions during the webinar, there is a Q&A box at the bottom of the screen. You can type your question into the box. At the end of Ann's presentation, we will take some time to answer a few of the questions live. I know we won't be able to get to all the questions this evening, but we will get to as many as we can. So our speaker for this evening is Ann Smith. We are very fortunate to have her with us this evening. Ann is a founding member of PRISMS. She chaired the Professional Advisory Board until 2011. She has dedicated 3 decades of her career to the study of Smith-Magenis Syndrome, which of course is the syndrome that she discovered with Ellen McGinnis back in the early 80s. And thank you so much for being with us here this evening. It's really a treat to have you as a speaker for one of our webinars. And really from the entire SMS community, thank you for all of your dedication to studying the syndrome, your dedication to our families, and for all of the work that you've done and continue to do with SMS. I know you have a lot of information to share with us this evening, so I guess it's time for us to get started.
Okay. Good evening. Good evening from my home here in Winchester, Virginia, and I welcome all of you who are in the United States, and there may be even a few of you down under enjoying your breakfast tomorrow. So it's a pleasure to be here with you this evening to talk to you about the history of Smith-Magenis Syndrome. For me, it's been a 39-year journey of science, a bit of serendipity, and also working with a wonderful multidisciplinary team at the National Institutes of Health. I do have a lot to cover this evening, so I'd like to move forward and start. Okay. Today, Smith-Magenis syndrome is a clinically recognized syndrome. Early on, we thought the estimated incidence was about 1 in 25,000 live births, but we've now revised that to about 1 in 15,000 births. It occurs worldwide and has been seen in all ethnic groups, and the vast majority of cases do occur sporadically or are de novo. The syndrome itself is defined by a very distinct pattern of physical, developmental, and behavioral features. One of the behavioral features, the sleep disturbance, is exceptional in that it's also associated with a novel inverted circadian rhythm, melatonin. We'll talk a bit about this later. Even though the syndrome is recognized, delayed diagnosis is quite common, and it's only recently as the newer molecular tools have become available, specifically the chromosome microarray, that this has led to increased diagnosis. The story of Smith-Magenis syndrome and its discovery really rests on many pillars. Obviously, scientific inquiry is very important, and the advances that were made technologically, as well as the rise of the field of clinical genetics. Allison alluded to the fact that I've been working over 30 years on Smith-Magenis, but actually I did my training as a genetic counselor and entered the field very much in its infancy, so in the frontier days of clinical genetics. The discovery of SMS obviously and understanding the syndrome has required a cadre of dedicated clinicians and researchers involved, working collaboratively also with the children and their families. So I see this as a research partnership. Also, we need ongoing support, and the support in terms of research dollars, and tonight, through PRISMS, this webinar, obviously, to increase awareness of Smith-Magenis syndrome around the world. And with all stories, there's always a touch of serendipity. And so my experience with Smith-Magenis began back in 1981. And if we look back, it's now 2020. That was 39 years ago when my journey to understand Smith-Magenis syndrome began. It all began with one child whose parents had brought him to Children's Hospital in Denver. And we're going to talk about him in a moment. However, I want to kind of bring you back in time to what it was like back in 1981. It coincided with the advent of the first IBM PC, and most of you have a cell phone that has much more computing power than was in this IBM PC launched in 1981. And I don't know, for some of you may remember the first portable computer, much the size and the heft of a sewing machine. This is the compact computer that I began work with, and I'm glad that things have evolved since that time. So going to the discovery of Smith-Magenis syndrome, as I mentioned, it all begins with that first child that I saw at Denver Children's Hospital. I was a much younger genetic counselor then, and I was asked to see this little boy on genetics consultation. He had been admitted to the hospital with a history of failure to thrive and had multiple feeding problems. And in fact, he was there at Children's Hospital to have a G-tube placed surgically. In addition, he was noted to have a defect of his heart. And on his medical chart, the records showed that he had been diagnosed with Pierre-Robin, very small jaw with associated cleft palate. And he had both urinary tract and renal anomalies. He had also failed his newborn hearing screen and was found to be congenitally deaf. So in seeing him, he presented with multiple anomalies, and I recommended a chromosome analysis. So truth be told, it really was the cytogenetics technician who was seeing his chromosomes under the microscope who truly did discover Smith-Magenis syndrome, because she looked at the chromosomes, and these are the original karyotype or chromosome spread, metaphase spread from 1981. And she felt that there was something unusual going on with the chromosome 17. And asked for another blood sample. At that time, we got another blood sample and we did what was known as high resolution chromosomes. And indeed, she documented that there was an interstitial deletion of chromosome 17p in the 11.2 band. Now, serendipity hit within 6 months of that, because I was asked to see a second little boy on genetics consultation. This little boy, a Hispanic young man, was in the hospital. He'd already had a repaired cleft lip, and he also had a defect of his heart. And once again, I made a recommendation for chromosomes, and ironically, it was the same cytogenetic technician who actually read out his chromosomes and called me excitedly on the telephone. Remember, we didn't have FaceTime and video phones at that time. We were dealing with the old-fashioned way of communicating. And she called me on the phone and said, I think we have a second case. And it's those two children in this very tiny abstract that I presented at the American Society of Human Genetics meeting in 1982, describing two children with heart defects and facial clefts and a previously undescribed chromosome abnormality involving chromosome 17. Now, that was my first talk in a large auditorium of over 500 people, and after presenting, I had the opportunity to see this woman who was quite short walking or running down the hall to try to catch me. And that turned out to be Dr. Ellen McGinnis. And Dr. McGinnis was a very famous cytogeneticist. And as soon as she saw the chromosomes that I presented on these two infants, she said, I have seen those chromosomes before. I'm going back to my laboratory. And she did go back to her laboratory at Oregon Health Sciences Center and pulled out an old file, and lo and behold, called me excitedly to say, I think I found an additional case. And so began our collaboration to find additional patients with chromosome 17p deletions and describe them. And that was what we did in 1986, which first clinically delineated this new syndrome associated with the deletion of chromosome 17p11.2. Now, at that time, obviously, as a genetic counselor, one of the roles or hats that I wore was to provide parents with information about the diagnosis for their child. In this case, obviously, for those families, we could say it was a chromosome abnormality. Also, what the cause was. Well, we knew now that it was an interstitial deletion of chromosome 17p. And because we had done parent chromosomes and they both were normal, we could give a recurrence risk that this was a de novo or sporadic event and likely to not carry a high recurrence risk. However, since there had not been any published cases in the literature, understanding what the medical or treatment recommendations might be were unknown at that time. Parents often want to know not only what the diagnosis is, but what does it mean for my child? Are there important treatments that might improve function? And also, there was really no group to refer them to provide support and advocacy, as PRISMS does for many families today. If we look at the history of Smith-Magenis syndrome, I've broken it down into 10-year decades here. After the initial description in 1982 and following with the paper in 1986, the syndrome got formally named. Instead of being deletion 17p11.2, it became known as Smith-Magenis syndrome in 1989. And then after that, additional papers, clinical delineation, helped expand the phenotype. Those were through additional case reports that occurred in the early 90s. And Dr. Frank Greenberg, who was then at Baylor College of Medicine, also brought a group of patients there to Baylor and reported out his findings. As we move into the new millennium, obviously additional advances made through the Human Genome Project also led to the understanding that one of the major genes involved in Smith-Magenis syndrome was RAI1. And in addition to that, the animal mouse model was first introduced in 2002. And as we continue to understand SMS, we were always looking for those effective treatment and management strategies that might benefit these children. So here we are in 2020, and we're looking to the future for what else will happen in this next 10 years. So going back to Smith-Magenis syndrome, today it is a well-recognized syndrome. In all cases, the children do present with early developmental delay and some level of cognitive or intellectual disability. It's associated with a distinct facial appearance and other characteristic physical features. I think you can see the facial appearance that's similar in these children, and we're going to talk a little bit about the motor signs later. But for most families, it's the lower half of this slide that a lot of the questions about what to do about behavior. So the syndrome has been defined as being associated with a distinct sleep disturbance associated with an inverted circadian rhythm of melatonin. So it's a circadian sleep disorder. And in addition, the behavioral aspects have been further codified. The striking behavioral phenotype described includes both repetitive and stereotypies in terms of behaviors, self-injurious behaviors, and a variety of other maladaptive behaviors. And in many cases, if the diagnosis of SMS has not been made, then oftentimes the children have also been given a dual diagnosis or a psychiatric diagnosis, such as attention deficit hyperactivity disorder or autism spectrum disorder. The history of cytogenetics and the advances made were very important to the identification of Smith-Magenis syndrome. This is the oldest patient known to have Smith-Magenis syndrome. She was born in 1919, and this is the same patient that Dr. Ellen McGinnis said, "I think I have a patient," and went back to study her. When she studied her chromosomes, she was 65, and that's when her diagnosis was made. But in 1919, she was born before we even knew how to look at chromosomes. The birth of cytogenetics did not occur until the 1950s. And the first chromosome abnormality to be described was Down syndrome, which is due to an abnormal chromosome number, or trisomy 21. It's only in the late 70s and 1980s when banding became available, and also the ability to do FISH. And here's some banded karyotype. Here's a normal 17, and you can see this little piece is missing. These are the original chromosomes from that first case. And now, with the advances of the Human Genome Project, we have a new technique called chromosome microarray, which actually is a molecular technique that lets you define the deletion, so you're not having to look down a microscope and guess whether there is a deletion. So this has changed the way the diagnosis is made in the last 10 years. I mentioned earlier that the diagnosis is often delayed, and when we looked early on in the early, let's say about 2006 at our population, the mean age of diagnosis was age 5 at that time. Today, the diagnosis is made by either confirmation of a deletion, which occurs in 90% of the cases. In the early days, this was by G-banded karyotype with FISH. More recently, since about 2010, when the chromosome microarray became the first tier tool to use for analyzing children who presented with developmental delay and multiple anomalies, that's now identifying additional cases. So we've gone from looking at human chromosomes now to having this new tool available that will detect the deletions. Among the deletion cases, about 70% are due to a common deletion, and 20% are due to smaller or larger deletions. I know that Rachel has already done a webinar on Genetics 101, so I'm not going to go into much more detail of that, but recognize that with the evolution of these techniques, the diagnosis is now being made at younger ages. In 2003, a major advance was made, and that was the work of Dr. Sarah Elsey. All of us who were working with Smith-Magenis then would have a few patients who, despite all attempts to look for a deletion, we couldn't find them. And she had these 3 individuals in her population where they could not find a deletion, and she set about trying to discern whether or not there might be a mutation in one of the genes involved in the deletion. And lo and behold, her work, it was actually of her graduate student, Dr. Schlager, they identified a mutation in RAI1, or retinoic acid-induced 1, as the cause of the Smith-Magenis syndrome phenotype in these individuals. So today, we know that individuals with the deletion account for about 90% of the cases. That deletion, RAI1 gene, sits right in the middle of this common deletion area. And in about 10% of cases, as with those first 3 patients, and we've had additional ones at NIH, a mutation or a spelling error has been identified in the RAI1 gene. With the identification of individuals with a mutation, obviously we are looking for additional cases. And initially, the phenotype of the mutation cases resembled very closely the phenotype of deletion cases. But as more individuals have been described, it is clear that among the mutation cases, there are a few phenotypic differences. And that's shown here in this slide in yellow. The first 2 children that I saw, who both had heart defects and clefts, and one of them had a renal anomaly, those particular types of structural defects have not been seen in any of the mutation cases. What is very prevalent in this, while a lot of the deletion cases are short and have short stature, that's not, that percentage of in mutation cases is much less. They tend to be taller. Also, we see a little lower frequency of middle ear problems, but what we do see universally among the mutation cases is obesity. And here you can see across different populations, in one study, all 9 were obese, 4 of 5, and 67% in the initial group of 13 cases published. So that's a very different rate than might be seen in the deletion cases, although we do see obesity, especially after age 9, among the deletion cases. And we'll talk a little bit more about genotype-phenotype correlation later. I mentioned earlier that the deletion includes a deletion of chromosome 17. It's right in the middle of this deletion interval. And there are a few other genes within that deletion interval that are deleted in individuals with the deletion. Some of these genes are of interest, and early on in the natural history study, we did do some study of certain areas or phenotypic areas. The gene MYL15A has been associated with sensory neural hearing loss. If one has a mutation in that gene on both chromosomes, then one would be deaf from birth, or congenital deafness is associated with that. Another gene of interest is SREB-F1, which is associated with lipid abnormalities. And we did look at our population in the natural history study and did document high cholesterol in a proportion of over half of the kids. So understanding the deletion is also important for this population. So we look now from Colorado in 1981. In 1990, my husband accepted a position in the Washington, D.C. area. So we moved with our family to Reston, Virginia. And it was there that I realized that there was a wonderful institution, the National Institutes of Health, that would be a wonderful place to work. And so with the advent of the Human Genome Project that arrived and began at NIH in the fall of 1993, I took a position at the NIH as a genetic counselor working with the Human Genome Project. And at NIH, it became apparent, I'm a genetic counselor. I'm not an expert in all aspects. I'm not a neurologist. I'm not a speech pathologist. But at NIH, we had all of those. So I worked to assemble a team, multidisciplinary research team of both basic scientists and clinical researchers that became the SMS research team. In addition, I also have a cohort of families over in Australia that I've seen through an SMS clinic held at Camp Breakaway. And maybe some of you families are listening this morning in Australia. So why a natural history study? Well, it's important that one of the things that a natural history study can do is tell you the range and clinical variability of findings that define a syndrome. It also helps you understand the natural progression and those age-related issues, and also to identify management strategies or other unmet needs that need to be addressed. Ultimately, one of the things that the natural history study does is also provide potential outcome measures that may be used in future clinical trials. If one takes a step back and thinks about Smith-Magenis syndrome, RAI1 and its deletion, obviously that's in every cell of the body, and those cells make up different tissues. And if we look at Smith-Magenis syndrome, it affects multiple body systems. And so it is considered a complex multi-system disorder. There's growth, an impact on growth, obviously the craniofacial development, the behavioral, the sleep, and other functional abnormalities, including developmental delay and intellectual disability. Vision and hearing is impacted, neuromuscular function, as well as some metabolism and biochemical findings. So in assembling the team, the research team at the NIH, I realized that going to different institutes besides the Genome Institute would be very important. And we began our research with a group of 12 individuals in 1997, and the natural history study was put together thanks to some bench to bedside awards that I earned, that I was able to obtain, though that provided money to help us start and initiate this research. So some of you have maybe met Dr. Wally Duncan, who has helped. He's a circadian biologist who's helped me understand more about the sleep disturbance. Our group of audiologists, Dr. Carmen Brewer and Dr. Chris Zalewski, have helped intentionally. And then we also have a variety of other specialists who have helped me at NIH as we've evaluated over 100 individuals at NIH and have enrolled over almost 200 individuals with SMS in our cohort. So if we look back to the early articles about Smith-Magenis syndrome, obviously when you start a natural history study, you start by looking at those features that have been described. And we knew that developmental and intellectual disability was a part of the syndrome, and parents had mentioned about a sleep disorder, so that was an early aspect of our research, and further refining the behavioral phenotype. But understanding the early speech delay, there was a very specific hoarse, deep voice. If you talk like that, that's a very characteristic voice in Smith-Magenis syndrome. A variety of issues that involved vision, the signs of a peripheral neuropathy or the decreased sensation to pain, a very small hands and feet or brachydactyly. 78% were felt to have short stature, and we knew about the progressive scoliosis. But from the natural history study, we added to that phenotype, and we began by bringing in young infants with Smith-Magenis on the early days of our protocol to really define the infant phenotype of SMS. And what we learned is that all of the children generally had infantile hypotonia, and often in the first year or two of life might be followed for evaluation for failure to thrive. At NIH, because of the craniofacial features, we were also interested in dental anomalies, which we have documented in a high proportion, and also further explored the middle ear and laryngeal abnormalities. I'm going to speak about several aspects of this, so I won't go into any detail, but I will mention autism spectrum disorder. Many of the individuals who we did see had come with the label of autism spectrum disorder. So using a screening tool, we looked at this population of patients that we had. And by the screening tool, depending on the criteria you would use, it would indicate that several of those children might fit with autism spectrum disorder, even though they were not truly autistic. Obesity, obviously we saw that among the deletion cases, but it is much more prevalent in the mutation cases. And I already mentioned about the documenting hypercholesterolemia, and we also saw lowered immunoglobulins in about half the individuals. But those first two children both had heart defects and cleft lip and palate. So as additional families and patients were described, what we learned was the incidence of those defects are much lower. So these are the variable features that we need to be aware of and think about when someone is newly diagnosed. But once we've checked for them, either by doing an echocardiogram or a renal ultrasound, then we can just follow and monitor. Once the diagnosis is made, one of the parts of the natural history study is to understand and discern the management issues that might need to be addressed. And so we collected old records retrospectively to look at what happened before, and we watched the children prospectively or longitudinally. But the management issues obviously related to their medical care, behavior, sleep, and for most of the children, all of them were involved with the PT, OT, or speech, or someone who was involved with helping with therapeutic interventions because of the developmental delay. Educationally, because of the speech delay and motor skills, talking about planning for school. And then there are a number of psychosocial issues that impact the family, whether it be the support of the primary caretaker, the respite needs of the parent who might not be sleeping because of the sleep disturbance. Overall, my feeling has always been that there needs to be a multidisciplinary team approach to caring for an individual with SMS, with the family and the child with SMS in the middle, surrounded by those care providers, the primary care physician and other specialists, as well as information through PRISMS. Working with PRISMS and the Professional Advisory Board, we have had the opportunity to put together the medical management guidelines and a checklist that are available through the website. The management guidelines are a little more in detail, and the checklist is, like it says, meant to be a simpler, easier thing, but looking across the age span, these management guidelines can be helpful to families and should be made available to your child's primary care provider. Well, what's in the management guidelines? I don't have time to go into all of that, but I suggest that you go to the website if you're not aware and find these PDFs. And I know that Allison was going to make the PDFs available to families if they're interested as well. But a multidisciplinary team evaluation at the time of evaluation to essentially look from top to toe, physical exam, looking for all aspects of things that we do know about the syndrome. We need to also understand, since the children are more prone to frequent otitis media and upper respiratory infections, an immunologic evaluation may be helpful. The involvement of allied health professionals such as PTs, OTs, and speech pathologists is very important, as well as other specialists based on the medical history. So in the multidisciplinary team, we cannot forget, though, the regular well-child care that needs to go on. So your child still needs to be followed regularly for annual checkups and follow the guidelines for all immunizations, etc., in their care. The natural history study, I'd like to kind of now set the stage of talking about different age groups and some of the different findings from our natural history study. And I'd like to first start by focusing on infancy and early childhood. I mentioned that we enrolled many young children early on in our study, and some of those children who were 6 months to 1 year of age now, 19 years later, are approaching adulthood. But when we look back on that, most of the children had normal birth parameters. They were born at term, and generally within that first year of life, they may have been referred for failure to thrive and further evaluation. And we now know that as we've looked at this is due to the significant oral sensory motor dysfunction with lots of feeding abnormalities, in part due to the low muscle tone. There's kind of a poor suck swallow. If you'll notice here, this open mouth posture that's very characteristic of these children. This little boy was actually eating his dinner and fell asleep. I'm sure you could send me pictures of your child also sleeping like that. What we also learned in addition is that a lot of the children had issues with reflux, gastroesophageal reflux. And when they were supposed to transition from essentially to solids, this was a difficult thing to do because of their difficulties chewing. In asking a lot of parents to describe their child during early infancy, oftentimes they would describe needing to awaken their children for feeds and also that they slept a lot. So this generalized lethargy and sleepiness in early infancy is pretty common finding among children with SMS. Although I must say that I've also heard an equal number of parents say that their child never seemed to sleep. Developmentally, they were delayed, and when you look at development, it was most often gross and fine motor delays that were noticed first. And when you actually looked at their social skills, those were more age appropriate. And one of the things that that can do is, if social skills are appropriate, the doctor may say, well, let's just wait and see how your child does. And that would defer having further evaluation or chromosome studies, and also lead to perhaps a delay in diagnosis. With respect to the early speech delay, the children often were not chronic criers. There was infrequent crying and diminished babbling. So they really were generally quiet, complacent babies. And if I had to think of a moniker to describe them in general, I would say they really were too good, too quiet, and often too sleepy. So early on in the study, it's very easy to get measures of height, weight, and head circumference, since those are obtained during the annual visits. And when we saw them at NIH, we would get those measurements. So we collected data and were able to actually document what the growth pattern was. And it validates the reason for seeing this failure to thrive is by that within the first 3 years of it, if they started out here in the normal range, by age 3, we're often below the 5th percentile. So this is a deceleration in their height parameters. As we've continued to collect growth parameters, we see that relative short stature often persists into early adolescence, with most of the individuals tracking at about the 5th percentile for age. And these are the curves. The dotted line here are the normative 95th, 50th, and 5th percentile. And I think you can see from these red lines here that the children still fall on the lower end of the curve. As the children get older, between the toddler and early school years, generally there's more recognition of the gross and fine motor delays. And it's generally at this point, because of the marked speech delay, if they haven't been referred for therapies, they are referred for further evaluation to understand what might be going wrong. The decreased sensitivity to pain is part of the peripheral neuropathy. And we often see very flat feet, and in some cases, a very high arch. The gait is unusual, and it's often very broad-based. And we've seen a lot of the children who are persistent toe walkers. Potty training is delayed, and we'll talk more about this later on. And as I mentioned, the children often, because of their sensory integration issues, on screening tools to look for autism spectrum disorder would fit the spectrum, generally, depending on the tool, about half of them, and another tool, if you go further, about 90%. From a sleep standpoint, while most parents don't really complain of major sleep problems under a year of age, by the age of 2 or 3, or at least by 18 months, I would say, they're often complaining that suddenly there's these nighttime awakenings, and that their child is an early riser, or defined as being a lark. And if I had to pick a common awake time in the morning, it would be between 5:30 and 6:30 in the morning. Whether it's here in the United States, Australia, France, anywhere, it does seem to be pretty universal that they do have this sleep disturbance that's marked by an advanced sleep phase. The nighttime awakenings generally occur after midnight, and because of those nighttime awakenings and the decreased total sleep time, there's a propensity for daytime naps, and as the children get older, the need for naps continues. The behavioral aspects of the syndrome in this early school age actually do increase, as the initial behavior that we might get described as head banging. And I think that sometimes that coincides with the fact that the children cannot express what they're thinking, and therefore a head bang really is a way to express what they're thinking. But we also see the evolution of the behavioral phenotype with the self-injurious behaviors, the hitting, the skin picking, the hand biting, and the repetitive stereotypies. Working with Beth Solomon, a speech pathologist at NIH, we focused in on the early speech delay and the other aspects that might explain these findings and documented the significant oral sensory motor issues with the poor suck swallow and the difficulties with feeding and then transitioning to solids. Once again, the diminished vocalizations for age, and overall we found deficits in how the tongue moves. The tongue has to move around the mouth and move the food, and also is important for that pre-speech. And the tongue motion and tongue strength was down. And we also commonly saw laryngeal abnormalities in this population. Recommendations early on that they be involved in a total communication program, where that would be using both the PECS, or the picture exchange system, talking verbally, and the use of sign language. When we looked at the evolution of full sentences and phrases by age, you can see here that the turquoise, generally by age 6, all of the children were talking in full sentences, but before that time they weren't. And so the use of some other facilitated communication program, this total communication approach, is very important in those early years. Since hearing is related to speech, I worked with 2 audiologists in the National Institute of Deafness and Communication Disorders, Dr. Carmen Brewer, and here you see Dr. Chris Zalewski. And we documented in the natural history study a high incidence of ear infections, or otitis media, of 3 infections or more per year in 80%, a common sinusitis in about 71%, other issues with tracheobronchial function in about half. Many of the children also had PE2 placements, or as they call it in Australia, grommets were placed. One of the parts of the audiogram or audiometric evaluation is a tympanogram, and this is a tympanogram here where this normal mountain look at the pressure of the middle ear is what you would expect, and what we saw in SMS was this flat tympanogram. And these were common in, we looked at 97 of our individuals evaluated at NIH, and the prevalence of this flat tympanogram was 44%. The other thing that happens with the ears is the tympanic membrane perforations, and so documenting that was important. Once again, turning to looking at the incidence of hearing loss was present in about 80%, but we also looked at the degree of hearing loss and the type of hearing loss. And what we found is that the severity of hearing loss goes from about slight to mild. Only just over a quarter here had perfectly normal hearing, and we saw variable hearing, evidence of hearing loss in the vast majority of individuals in our study. But what we also learned was the type of hearing loss is different. And for children under the age of 10, the most common hearing loss was conductive, whereas after age 10, we started seeing an increased incidence of sensory neural deafness. Parents also reported that the children were frequently covering their ears with sudden sounds, and Dr. Carmen Brewer was aware of a questionnaire that had been used for Williams syndrome, looking at hyperacusis, which is a prevalent finding in Williams syndrome. We used that same validated questionnaire in SMS, and using that documented that almost 75% of the individuals would meet criteria for hyperacusis. Over time, as the children get older, we see a pattern of fluctuation of hearing loss and progression with age. Here is the audiogram from this young gal when she was 5 years old, and then again at age 15. She has a slight conductive hearing loss at age 5, and by age 15, she has a mixed loss that has both a sensory neural and conductive component. In terms of the hyperacusis, once again, that's a hyper or heightened perception to sound. We used our siblings as controls, and among the SMS population, almost 75% had features that would be consistent with hyperacusis, compared with only 12.5% in our sibling group. The highest severity in the tool was for usually these sudden types of sounds, such as fireworks, balloon bursts, or sudden shouts. So it's responding to those sudden, unexpected sounds. And when the children were particularly tired or more moody, this often triggered a greater reaction. And some of the reactions that the parents defined was covering their ears, getting quite upset, or suddenly getting markedly tense and anxious. We have learned, obviously, in working with families and listening to parents and understanding about this hyperacusis, that there are a number of palliative strategies that might be used with this population. If you anticipate going to an event that's going to have a sudden sound, such as 4th of July fireworks, it would be important perhaps to warn your child before, or to perhaps use sound dampening headphones or earplugs to help them avoid hearing those sounds that might set them off with a major behavior. Vision-wise, many of the infants, we documented strabismus. That's where in-turning or out-turning of one of the eyes instead of being perfectly straight. One of the easiest ways to document strabismus is the old-fashioned way of taking photos in that photo shoot of the red eye. If it's not perfectly parallel but deviates, then that would suggest that there could be strabismus. But in addition, the early eye findings also include microcornea, or a smaller cornea, which is pictured here. Other iris abnormalities, and in this case, this is different or irregular iris pigmentation. And refractive error. Most of the children who need glasses is because of myopia or high myopia, so they're nearsighted. And the corrective treatment for that would be the same as in the general population. Here you see a young man with Smith-Magenis who has esotropia, this in-turning of this eye here towards the nose. And this young lady also has esotropia, but she's wearing glasses that are also correcting that. So that's another thing. I want to make one mention of the fact that this population is at risk for detached retinas. There is a connective tissue aspect, and with the repetitive headbanging, one would have a concern that they potentially could be at risk to detach their retina. So we do recommend protective helmets if headbanging becomes such an issue, just to help prevent that. Craniofacial-wise, in the early studies of SMS, we began by giving descriptions of the craniofacial appearance. These are more subjective, but in genetics, we often do a lot of measurements in looking at that, and working with Judith Allenson, we've published our data on the objective pattern analysis that looks at inner canthal, outer canthal distance, and different measurements taken of the face. And these support the impression of this very flat nasal bridge, kind of broad. And some of you may have also participated when Dr. Peter Hammond from the UK came with his 3D imaging machine. And today, facial imaging is such a common thing, but in those days, it was a major to-do, I should say, to get those cameras set up so that we could take these 3D facial images. And that allowed us to look at the face in three dimensions. And what we now know is that this part of the mid-face is not growing while the lower part of the face continues to grow, so that marked mid-face hypoplasia and this very unusual downturned mouth are very characteristic of the syndrome, and help define the facial imaging that we now see and refer to. At the NIH, I also met a geneticist who was a dentist there doing her training, and she was looking for a project. Well, I always have a project with Smith-Magenis in mind, and so working with Natalia Timona, we began looking at the dental issues in Smith-Magenis syndrome. And one of the things that we learned about that is that there is a high preponderance of dental issues. First of all, we documented that congenital absence of secondary teeth, especially the secondary premolars here, was common in this population. Another unusual finding, toroodontism, which is shown here, which is the different shape or diameter of this pulp chamber. Now, this isn't going to affect chewing, but it is a different shape to the tooth and a finding of note. The other aspect is this open bite. So when you chew, you really should have your teeth come down in a certain way, and oftentimes they have this open bite and kind of almost an overbite, which makes it more difficult for them to chew all of those harder textured foods. We also documented macroglossia, or large tongue, in almost half of the cases, and evidence of teeth grinding or bruxism was apparent in about 44% of cases. What we also learned, because we had young children and older children, is that the oral habits or dental hygiene in the younger group was pretty good, but in the older group is a major issue. And they care for that in terms of having increased cavities, other types of dental hygiene issues, makes this an area that we need to help assist them with their brushing. The x-ray here, just I want to point out one thing here of a finding, which is this cephalometric thing. When we talked about the relative prognathism, you can see how these lower teeth are somewhat protruding, pushing out this upper lip. Here, it's a little bit better, you can see that. And I've been getting a lot of questions recently about the need for orthodontics. I can tell you that we've had some SMSers who've tried orthodontics and some who've pulled the braces off. So I think this recognizing that the craniofacial structure that underlies SMS, that there is a different growth rate, that should be all incorporated into your discussions with, if you are thinking or planning about orthodontic care. Muscle-wise, low muscle tone is common, especially at young ages, but that seems to persist. And the children have this truncal hypotonia that makes it difficult for them to, well, let's say they need to do a lot more exercise to improve their truncal tone. There's generalized gross muscle weakness, and when you test the reflexes, oftentimes they're decreased or hyporeflexia. The joints can be hypermobile, and we also see, as they get older, a propensity of scoliosis and lordosis. Typical feet here, these very flat feet and very small, and these thinner lower legs. This is the typical infant foot, and a persistent fetal pad, this little bump here at the base of the toe. This young lady is having a little more difficulty when a ball is thrown at her, trying to catch it and throw it back. One of the things we have learned is that equine therapy can be very beneficial to individuals with SMS. It may help with their posture. It certainly helps with their truncal hypotonia. The gait abnormalities of this broad-based gait, we have followed some of the children, and we continue to see persistent toe walking. And if you walk on your toes a lot, your heel cords are going to get tight, and then that presents another issue in terms of dealing with, in terms of their gait. Scoliosis is an issue in about 75% of patients. They don't present as infants with scoliosis, but we monitor them as they get older, and we have seen it progress. In the first child that I saw, he also had a vertebral anomaly, so we also need to think about, and one of the standard things we do as part of the natural history study was to do baseline spine films to look for vertebral anomalies. And then those can be used as you clinically continue to monitor for scoliosis. It serves as the baseline in terms of a straight spine versus how curved the spine gets with age. We now have a newer finding that we've seen in 3 older individuals, and that's spinal stenosis, or the narrowing up in the cervical spine and also the lumbar spine. So we need to be cognizant of that and look for that as individuals get older. Working with the physical therapist Michelle Smith at NIH, a number of our individuals who come to NIH have also been fitted for orthotics, which actually gives them a better arch support. This means that they need to wear a good shoe with a good toe box, and a Croc, which is a favorite shoe of many SMSers, is not the best shoe for this population. From a fine motor standpoint, essentially the fine motor skills are delayed in SMS. One of the early motor skills is a pincer grasp, and oftentimes this is quite delayed. This is this prehension, and you can see this older teenager here. She's actually almost still raking as she's working with this puzzle. The thumb joint laxity and the supermobile joints make it difficult to hold a pen, and that makes the motions that writing might be. The children are probably never going to be the perfect penmanship in the classroom. But there are some things that can be used to help them as they learn to write. And there are a lot of different things that Hannah Hildebrand, the occupational therapist who's worked with me, has written about, and I'm happy to share that if there are specific questions. While working with families, one of the things I've learned over the years is to listen to the questions that parents have. It was a question from a parent about sleep that led us on the cascade to understanding the sleep disturbance. And it's the constant questions about talking about constipation, a little known medical issue that few people look at, that led me to find Myra Woolery, who is a nurse at NIH, who was actually getting her PhD by doing a study of constipation in a pediatric oncology patient population. Well, using her tool, the PCAS, the Pediatric Constipation Assessment Survey, we used that with the SMS population. And in 1998, when I first looked at the issue of constipation, about 53% of parents would report that might be an issue. But when we used this new tool that she developed more specifically, and also our sibling cohort, what we found was that the incidence of constipation was much higher than originally estimated, about 80%. And because we have the Australian cohort, I had not heard as many complaints. I thought, well, maybe constipation is not as bad in that population, but lo and behold, the rates were similar in both the US and Australia population. And overall, they're much higher than what would be published for pediatric population, which is about 12%. So this remains a chronic issue. And if you think about constipation, it can greatly influence your behavior, your general comfort level, mood, activity, and appetite. And many times when we sent the children to have an x-ray of their spine, what would be noted on that x-ray, because it includes the abdomen, was the fact that the stool was backed up a lot. So it's another quick and inexpensive way to check for marked constipation or fetal impaction. A word about toilet training. I understood that a few questions had come in recently, and what I'd like to share with you is some of our data that looked at this. It tends to occur later in children with SMS than compared to the normative population. If we break down toilet training in terms of bowel control versus bladder control, daytime training is what appears first, and bowel control average about 4 to 5 years of age, with the bladder about 4.1 year, about 4 to 5 again. But when we look at evening training during the night, bladder training is significantly later. The expected time would be 5 years of age based on the American Academy of Pediatrics publications. But in SMS, we found the average age was 8.2 years, but there was a considerable range, and that range was anywhere from 3 to 20. So this may be individually an issue for your child. It's something that perhaps we should have all bought stock in Huggies pull-ups, because they seem to be something that's used by a number of the children. The other thing that we looked at, once they did have trained at nighttime in terms of their continence, that there was a difference between males and females. And it took a little bit longer for the females to be totally continent than for the males. In terms of development, finding an IQ level in SMS can be quite a challenge. When it has been measured or reported, it can range from 20 to 78, so it's highly variable. But most of the individuals fall into the moderate range of intellectual disability. But in testing them, it is clear that there are general weaknesses and strengths. And the weaknesses tend to be in sequential processing and their short-term memory, while their strengths are long-term memory and perceptual closure. Perceptual closure is showing a picture that's not complete and filling in the rest of the picture. We do know that children with SMS are very visual learners, and they have a way of putting all those pieces together, so it's not surprising to find that that is something that is a skill for them. We've already talked a lot about the early speech and language delays. The majority of individuals with SMS will be speaking in full sentences by the age of 5 or 6. I have a few individuals who are nonverbal, but this is the exception, not the rule. And I do find that there are several parents who say, if I'd known they'd speak so much, now that they have an older individual, they just don't stop talking. They become almost loquacious in their communication and asking questions. Brenda Finucane added to this literature of coining the term inner toddler in terms of the emotional development. And she described what we know now as a developmental asynchrony, and this is the uneven rate of development between cognitive function and emotional development. At NIH, we also looked at adaptive function compared to IQ and found some interesting results. This in yellow is the IQ scores and the average in a cohort that we published in 2006. And what we found is that the communication skills and the daily living skills were pretty consistent with what you'd expect for their level of cognitive function. However, their socialization skills were much higher and out of sync. So they were doing much better there, and that would lead you to think that they should be able to do better in other areas. And once again, I think this is this developmental part of this developmental asynchrony between the cognitive and then their emotional reaction as well. The neural behavioral phenotype has been defined to include not only developmental delay and the sleep disturbance, but a striking pattern of behavioral aspects that include both these repetitive behaviors. Brenda Finucane again described what's known as the self-hug, and that's the hug could be like this, it could be like this, it could be like this. And Dr. Elizabeth Dykins in some of our early work together also described this lick and flip behavior, which is a page-turning behavior, doesn't always have to have the lick. That seems to be pretty prevalent. In terms of the maladaptive and self-injurious behaviors, the attention-seeking, especially as they get older, this continues to be an issue. The marked temper tantrums or expressive outbursts that are often not predictable, the impulsivity or obsessions with certain types of things, the rapid mood shifts. I mentioned many of the children might have been given the diagnosis of ADHD because of this attention deficit or their hyperactivity. And as we see the older individuals in the teenage years, there is this increased anxiety, and we have had a lot more descriptions of a fight or flight response. The psychiatric comorbidities we've already kind of touched upon. In terms of the self-injurious behavior, the more common ones are listed here of biting oneself or hitting oneself. Two of the behaviors that seem to be pretty specific for SMS, onychotillomania or nail yanking, or polyembolicolomania, object insertion into body orifices, if one looks at these actually tend to be behaviors at older ages. And because we know about them, actually interventions have probably changed the overall frequency of these behaviors, because we can get in and perhaps for the nail yanking, just even having frequent manicures or keeping the nails well trimmed so that they don't get like a hangnail and are ready to be yanked. I think you can see from the biting, and here's some nail damage from the nail yanking, and the constant skin picking. But the opposite side of the coin from the negative behaviors are the very, very many positive attributes or behaviors that are observed in this population. In general, these tend to be very loving children. They're engaging. They want to have you involved in their lives. They love to be helpers, and many of them have this great sense of humor. I always say that maybe Jerry Seinfeld has a gene in this region. They have a phenomenal long-term memory, better than mine right now. Many of them, when they come back to NIH, remembered everywhere they went, all the people they met, and they keep asking questions for why the cafeteria moved from one floor to another, or et cetera, et cetera. They have this wonderful ability to remember things and tell those stories. They're very inquisitive, and in general, in the era of 2020 or the information age, they have a fascination with electronics, computers, and buttons, and are able to find their way around computers or use digital electronic toys with quite a finesse. Sensory processing issues, working with Hannah Hildebrand, we published that in 2012, but all of the senses are impacted in SMS. Their perception visually, what they hear auditorially, the balance that you get, vestibular function, all of those are impacted in SMS. And it's important to know about these because these are things that we might be able to help or assist them with as they are in the classroom. So tactily defensive, auditory defensive, very distractible. So in the classroom where there might be noise going on, they may hear something else, easily distracted from the job that they're supposed to do. There also are balance issues, so it may take a bigger signal for them to respond to something, or a little small signal will make them really respond. So this is also part of the proprioceptive and vestibular signaling. In many cases, we think that sensory seeking, they may be seeking sensory input as opposed to, in other cases, avoiding sensory input. So all of these aspects are part of that. And as they work through all of this, understanding that and trying to come up with modifications that can help them will be very important in working with your child. I have used the analogy of a bicycle to, when I think about the behavioral aspects of SMS. A bicycle with 10 gears. That big gear, the little gear, and all the gears in between that help modulate or fine-tune behavior. And this is what is not working in SMS. They have the big gear and the little gear, but those other gears in between that make things modulate and more fine-tuned are impacted. So this is in respect to their activity level, their rapid mood shifts or their affect, their attention. They do seek a lot of attention, especially from adults. It also is the bodily functions. We talked about toileting and sleep. They may be seeking food. They may be overeating. And the sensory issues, once again, sensory seekers or sensory avoiders. And they may have a very low registration versus a high sensitivity. So it takes a signal to cause them to have a reaction that has to be very high, or it may be the smallest amount that sets them off. We also have seen that as they get older, and if their IQ is higher, there is an increased, the maladaptive behaviors kind of build their repertoire. So the older they are, there will be more things in their behavioral bag of tricks. And the less cognitively impaired, they're able to pull out even more tricks. When we did work with Dr. Elizabeth Dykins, we actually looked at a lot of these behaviors relative to sleep parameters. And what we found was that the strongest predictor of the behavioral problems was sleep. So modulating their responses to everything that they're trying to address, everything that's coming in, whether it's a sound coming in, whether it's something they want to express that they're feeling, their impulsivity, being frustrated, on top of that, being very tired. It's often difficult to keep a lid on everything for them. I think I've asked parents to send me pictures over the years of their child sleeping, and in all positions, all places, if wheels are turning. This is a collection of several pictures of different children, and sleep is a major aspect of this disorder. While I'm not going to spend a lot of time on sleep, I have told Allison in PRISMS that I'd be happy to do another webinar specifically talking about sleep, but I've included a few slides here to illustrate some important points. So once again, in infancy, generally parents are not complaining too much about sleep, and it's usually by that first year of age that suddenly aspects of the sleep disturbance start raising their head. So as infants, they may be sleeping too much. They're often generally quite sleepy and quiet. But what we learned when we use actigraphy on a population as young as 9 months, we documented the sleep disturbance. It's just that they were not crying out or alerting the parent that they were awake. As the children get older, generally there's not as many difficulties falling asleep. And in fact, this young man has fallen asleep in his spaghetti at dinner, which is a common thing to occur. We have seen as the children get older in the teenage years, they may have a little more difficulty settling to sleep, which is not unusual, but still the bedtime tends to be earlier. And the total sleep time across all ages tends to be less. So if we look at their 24-hour sleep amount of time using actigraphy, it's about 1 hour less compared to their control siblings. The awakenings, as I mentioned, happen generally after midnight, and they can be 1, 2, or 3 a night. And generally, they're ready to start their day at 5:30 or 6 in the morning. So we call these parameters of the descriptor of the sleep being an advanced sleep phase. And this leads to a chronic sleep debt of having not enough sleep the next day, which then puts them at feeling that they need to have a daytime nap. So what we've also learned as they get older, one might anticipate you need fewer naps as you get older, but not in Smith-Magenis syndrome. Children with developmental disabilities do have sleep disturbances, but what distinguishes the sleep disturbance in Smith-Magenis syndrome is this novel inverted circadian rhythm of melatonin with a daytime high versus being high at night. So we consider the sleep disturbance in SMS a true circadian disorder. Melatonin, as many of you know, is a hormone of the night, and all species make it, and it should be produced in the middle of the night. I think of it as the signal to the cells of the body that don't know what time of day it is, that it's night. However, in SMS, it's the exception to the rule. So in control individuals who would have high melatonin at night, SMS have it high during the day. This is the control. So night high in SMS would be high in the day. So they are the exception to the rule. So the combination of that daytime melatonin, a bit like taking a sleeping pill and having to be a night shift body living in a day shift world, the expectations from school and this chronic sleep debt, that all leads to what we call the perfect SMS storm. So since every night is a hard day's night in SMS, what are the things that really we need to be thinking about? Well, for the child with that chronic sleep debt, they are constantly trying to fight that urge to sleep during the day. That's going to affect their daytime functioning, their attention span, their mood, their general activity. And at night, when they waken up at night, we get this food foraging behavior and wandering. And that is going to have a significant impact also on the family and the primary caretaker who has safety concerns for their child, who might wander out of the bedroom, sometimes wander out of the house, how to keep them safe, how to encourage them to have sleep. And yet the parent also may also have their own sleep problem because they're constantly on alert, listening for their child if they should wake up. Families with SMS have done a variety of things to help make their child sleep. And even before getting a diagnosis, if you talk with some families, you find that they come up with similar strategies. One family in Australia has built this special enclosure bed, and this is the old Vail bed that's an enclosure bed, and many of you are familiar with the safety sleeper. So trying to encourage them to stay in one place. In the school setting, it's also important to make accommodations for a scheduled nap. And while this is not ideal, at least this is an area that's quiet and off away from the other children, so this young lady can catch her sleep. So having worked with Smith-Magenis in the natural history study since 2001, that brings us 19 years to today. So now we're just getting into adulthood. We have a few understanding of a few adult issues. They seem to have fewer issues with balance and incoordination. They generally tend to be very communicative and especially love to talk on topics of interest and talk ad nauseum, and they will bring up the same topic often many times. We do feel that the cognitive function appears to be preserved into adulthood. So we don't see a major decline, or we haven't noted that yet. But as I mentioned, Brenda Finucane, who defined this developmental asynchrony, that we do see this unbalance between their cognitive function and their emotional level. With age, the number and severity of behaviors may increase. They may be more argumentative. You may see a little more aggressive and explosive outbursts. Their bodies are bigger, so they can do a little more damage to some property. And anxiety becomes a major issue. And we have had several instances where the fight or flight or stress response has been major, such that causes a great concern for families. Sleep, on the other hand, parents often say things are better with sleep, but while we've documented that the sleep is less, generally parents are ecstatic when they go from waking up at 5:30 or 6 in the morning to waking up at 7 or 7:30 in the morning. The other thing that we're aware of is that among females, they seem to be more prone to develop seizures with the onset of their menses. We've had a couple of males where this is the case. So it's one of the things to be aware of at puberty. If you do see evidence of seizures, that further follow-up and evaluation of that would be important. And because they tend to be sedentary in their activities and tend to do the food foraging or the hyperphagia, obesity becomes an issue, and health-wise obesity can lead to other cascades of issues that we are aware about in other adults as well. In general, we understand that as adults that they continue to require support from their caregivers. They are a vulnerable population. They know no enemy, and they like to be friends with all, so we have to be concerned about that. And we have found that they do require a higher degree of support than one might have predicted based on their cognitive level of functioning. I'd like to shift gears a little bit. Most of my professional life has been with a clinical hat on, working at the bedside, understanding the clinical ramifications, but the story of SMS would also include many wonderful bench researchers who are doing basic research. And in 2002, at the PRISMS meeting that was held in Denver, we were introduced to the first SMS mouse by the laboratory of Jim Lupsky. But other groups, including Dr. Elsey's, have also developed mice that mimic many of the findings of Smith-Magenis syndrome. These could be deletion mice here. I think you can see the normal mouse, and this, they named this the SMS deletion mouse. And here are two different mice. One is a wild type or normal mouse, and one with the RAI1 mutation. I think you can see that they tend to be a little more rotund or obese, but they're also in these mouse models, there also is a consistency, some other findings that are seen in the human population, including the craniofacial or skeletal abnormalities. The nose and snout is a little shorter. The wider span between the eyes or hypertelorism, the development of seizures or this low activity, and also some elegant work in Dr. Elsey's lab about the abnormal circadian period. So with that basic research, then coming back to looking at the growth curves for SMSers in general, we also see this increased weight gain that we see in the mouse. So there is in SMS a propensity to obesity, and this is something that in terms of management guidelines, thinking about strategies to work on this are going to be something to focus on in the future. These are growth curves for both males and females, and the dotted line once again, the 5th, the 50th, and the 95th percentile. I think you can see here by the red line that we have a number of individuals who are way above that 95th percentile, and 50% of the SMSers are also closely approximating the 95th percentile. So obesity will be something that is going to garner additional research. But there are a number of factors that also may impact obesity. This includes both dietary preferences, the sleep disturbance, the awakening and the hyperphagia, the food foraging at night, especially at older ages where they can get down to the kitchen and cook up quite a storm. Plus the fact that they also tend to be quite sedentary, so they're not really expending all those calories they're eating. The preference would be to watch TV or sit with the computer as opposed to being outside and exercising all day. And we do get complaints of exercise fatigue. Then when you add into that the use of psychotropic medications for the behavior, many of those are also obesity prone, in other words, cause increased weight gain. And this graph here, the red squares are the RAI1 cases compared to the deletion black dot cases. And you can see that obesity is much more prevalent in the mutation cases, but is an issue for the deletion cases as well. So that gets me to my soapbox of saying, get outside and get moving. And I think that's something that all of us here in the United States could benefit from as well, including myself. But get active. We actually have several Special Olympians. Here's a Special Olympian in Australia skiing. We've also had them running and swimming. Also, make activities fun. This young lady, older adult actually, is loving her aerobics class. Well, why does she love her aerobics class? She has a mirror, so she can actually observe and see everything that's going on. So when picking activities for your child, pick things that are fun, that get them engaged, get your whole family out, and keep them moving from a young age. Now that we've talked a lot about the syndrome, I'd like to spend the last part of my talk kind of in the area of support and advocacy. And tonight's is being brought to you by PRISMS, which obviously has had a very important part in the lives of many families with SMS. Many of you already know Maggie and Scott Miller and their daughter Deirdre and son Patrick. Well, I want to tell you, I first met Deirdre when she was 6 months old, when my husband moved me to Reston, Virginia. And one of my first friends was Maggie Miller, who called on a cold call to ask me if she could come over and visit, that her daughter had just been diagnosed with Smith-Magenis Syndrome. So I've known Maggie longer than I've known other people here in the Washington, D.C. area. And it was with Maggie that the discussions began around a kitchen table talking about the need for a support group. Coincidentally to that, Brenda Finucane here, shown here, with Frank Greenberg and Jim Lubsky. Here's a young Scott and another person in the back. Elwyn always had an SMS day, and so we went up there for a picnic, and working with Brenda and Maggie and myself talked about formation of a support group, which eventually became PRISMS. The major aims of PRISMS in those early days, once it was incorporated in 1993, was to provide a network of support. Well, now we're worldwide, and PRISMS continues to serve as an information clearinghouse for information about Smith-Magenis syndrome, also developing programs that benefit the individual person with SMS, and working to support and promote research into the causes, management, and treatment of SMS. Over the years, I've had the wonderful opportunity to gather the groups together at genetics meetings, and this is one of our main genetics conferences where we had all had dinner together. A younger Brenda Finucane, Ellen McGinnis, a younger Ann Smith, and a much younger Jim Lubsky. I want you to all appreciate that PRISMS has come a long way. This logo here, I'm so fortunate that we have a graphic artist with PRISMS compared to my first try at making a logo for our group. PRISMS also, we began our first research clinic at NIH with 12 families in 1997. The reason or rationale for that was in discussions with Maggie, we thought, well, we should have a conference. But what if we had a conference and no one came? So by having 12 families at the clinic, we thought, well, at least have 12 families at that first conference. And in 1997, in Bethesda, Maryland, at the Holiday Inn, we gathered all the families, and I think you can see this is the early group, and we were much more than just 12 families. And that has continued today, and now we're looking into July, and I hope all of you will join us in Dallas, Texas for Envisioning the Possibilities, the 11th International Conference for PRISMS. Lastly, just a couple of things for PRISMS to highlight some other aspects is we have a library for PRISMS, the management guidelines, but there are also some other wonderful books. The Guidebook for Schools by Brenda Finucane and Barbara Haas-Givler, and parents of adults have also written a wonderful adult residential living guide. PRISMS is now global. Thanks to Sally Hunt in the UK, we have a map that puts all the families around the world. There are groups that I have had the wonderful opportunity to visit. My last trip last May was down to Brazil, and now the world is totally connected thanks to the ability of the digital age. I've also had a wonderful opportunity to have and meet with an international team of investigators interested in Smith-Magenis syndrome. My SMS research team is down here. The late Frank Greenberg, who some of you may have met, very early group of early researchers. Here, Dr. Sarah Elsey, much younger, and a much younger group here. Dr. Lubsky's group, Dr. Elsey's lab, my newest collaborators in Botucatu, Sao Paulo, Brazil, Brenda and Barbara, of course, Helene DeLeer-Schneider and Peter Hammond. The list goes on and on, but most of all, I wanted to thank, besides my research team, is to thank all of the families who over the years have been so patient with us and participated in our research in the natural history study at NIH. And this is a list of all of them. It's on their heels that I'm presenting all this data. Their hard work has been very integral to understanding Smith-Magenis syndrome. So today, 2020, I look back, next year it will be exactly 4 decades, where I began in the Rocky Mountains of Colorado with the story of SMS. I have continued on my journey, and today the story continues. I'd also like to give a special notice to the late Ellen McGinnis. Dr. Ellen McGinnis was a wonderful collaborator, and I had the wonderful honor of working with her for many years. And with that, I'll say if there are any questions.
Thank you, Anne, so much for that incredible presentation. What a great resource for the SMS community. We appreciate all of the work that you've done, and I know this is really going to help families a lot to have this presentation recorded. So thank you very much. Before we move on to the question and answer portion of our webinar, I have a brief video to show you to introduce you to a wonderful family and also more founding members of PRISMS, and already really introduced them, but I want to show you a quick video to introduce the Millers, Maggie, Scott, and Deidre.
Hi there, we are the Miller family. I'm Maggie Miller.
I'm Scott Miller.
And you are? Deirdre was diagnosed with Smith-Magenis Syndrome when she was 6 months old. And at that time, there was almost no information available about SMS. And what was available to us was only a description of the most devastating characteristics of SMS. There was no information about what to do next, what to expect, or any spark of hope or encouragement. But a week later, we met Ann Smith. It was a meeting that changed the path of our next steps, and within a few months, we had our first meeting with Brenda Finucane, and the beginning plans of PRISMS were born. We will be forever grateful to Anne and Brenda and the dedication to create an organization that serves the SMS community. Deirdre has a happy life, would you say so? Yes? Despite her challenges, she is always busy between attending her wonderful day program and other social activities that include dance classes, exercise classes, and activities at her church. She is happiest when she is with her family, especially spending time with her brother, her many, many cousins, and particularly her time with her Nana, with whom she has a very special bond. Deirdre is a lifelong learner and continues to surprise us by mastering new skills and overcoming some trials. It is not an easy life, as you all know, but she has come a long way. If you have received the devastating diagnosis of SMS for your child, you are swept up in a whirlwind of sadness, confusion, and grief. But you have also landed in a phenomenal community that is here for you. We will walk alongside you through the tears and encourage you on the most difficult days. We will also cheer and applaud your child when you share their accomplishments and good days. This community is good and kind and inspiring. Thank you for letting us share our story with you. Say goodbye. Goodbye.
Bye.
Thank you, Millers, for that incredible presentation, or putting that video together and sharing your story with us. You guys are truly pillars of the wonderful community that you talked about. Now it's time for us. We are going to move on to the question and answer portion of our webinar. We won't be able to get to all of the questions this evening, but we will get to as many as we can. And
Okay.
let's see. All right. So our first question this evening for you, Anne. Bear with me one second. Okay. What lab work is required to determine if someone has a deletion or mutation? Was the FISH test able to determine that, or does it require the microarray or some other test?
I think it's an excellent question, and I think it all depends on the year at which your child was diagnosed. In the early days, a chromosome study with FISH should be sufficient to detect the deletion, and that's detectable in 90 to 95% of cases. However, the difference would be with a mutation. If no deletion is found, then one needs to sequence the specific gene, RAI1. And I would refer you back to the Genetics 101 webinar that Rachel presented, which really breaks this down in a lot more detail. My assumption is that if your child was diagnosed with a deletion, that should be sufficient. That has already confirmed the diagnosis. If you suspect your child has SMS after listening tonight or from reading, but no deletion has been found, then today the test that would be done would be a chromosome microarray to look for a deletion. And if not, then you would need to go and do additional testing to sequence for a gene mutation. Hopefully, the other webinar can also answer additional questions that you have about this.
Thank you so much, Anne, for that clarification. I appreciate that. Okay, so our next question is, are there any correlations with SMS and a certain ethnic group?
Once again, as I mentioned, SMS has been identified in all ethnic groups. The initial groups obviously were those who were here in America, but since that time, I am aware of individuals all worldwide in Japan and Russia and Finland and Australia, in the European continent, etc. But your question is there something that distinguishes one ethnic group from another? And they seem to be the same, although the recognition might be a little more different depending on what the cytogenetic techniques are in different countries. So there may be more variability of the genetic testing that's done, although that also is pretty much equalized around the world now. But early on, let's say 20 years ago, that was a difference. So I am not aware, there's really not a correlation of SMS with any specific ethnic group. It's seen in all ethnic groups.
Okay, thank you. That is, thank you for that explanation. And our next question is, what kind of medical approaches are available for sleep disorder in the US? Because melatonin dose does nothing for my daughter of the age of 6 living in Japan.
Okay. Once again, a good question. We've learned a lot about the sleep disturbance, and obviously different things have been tried. If melatonin has been tried for your child and is not working, one of the things I might ask first would be what the dose of melatonin is. We try to keep the dose of melatonin when it's used less than 3 milligrams because we want it out of the body system by the next day when their body would secrete melatonin. With that said, the other aspects are starting with the sleep environment. A dark room, few interactive toys, trying to stick to a routine, maybe a cooler room, trying to change the environment that encourages sleep. Start with that first. The other aspect of a treatment, it doesn't specifically help with the sleep, but it can help with the daytime melatonin, is the use of beta blockers. And then the French study coupled the use of beta blockers with giving the melatonin at night. And there is a current trial being done here in the United States by Vanda Pharmaceuticals that looking at the use of a medication for they originally used it for non-24 for people who were blind, but it's being tried now in SMS. That has not been finalized. I think some of the early data is encouraging, so there may be newer strategies down the road. With that said, other medications have been tried, but I think it's one of the things to work with a doctor or a physician with trying to think about what that approach should be for your child. And I'm happy to be available if you want to consult offline, because there are a few other questions I would ask before going to other medications.
Thank you. Thank you so much for that answer. And I have one last question for you before we conclude. The last question is, does behavior seem to stabilize somewhat once the child is fully verbal?
Does behavior, say the question again?
Sure. Does behavior seem to stabilize somewhat once the child is fully verbal?
Well, once the child is fully verbal, the behavioral aspects of SMS, you're still going to see perhaps some of the anxiety or the rapid mood shifting. But if they can communicate and you work to have them express what they're feeling, you may not see some of the other behaviors that are precipitated by the head banging and other aspects there. And what we see is that they continue to make gains over time. It's just that their slower trajectory than would be anticipated for the normal population.
Okay. Thank you. Go ahead. I'm sorry to interrupt. Go ahead.
I see one last question that came in.
Okay.
But it has to do with what happened to your research team, etc. Am I still doing SMS research either at NIH? And I think what's important to share with everyone is as I'm moving closer to full retirement, I'm not retired yet, I'm trying to essentially take all the research data that we gathered and write it up and have papers out of it so that we continue our understanding of SMS. It would be wonderful if there was a young whippersnapper researcher who would be welcome to come in, and there are still plenty of areas to research. I am still at NIH, and I would anticipate when I retire from NIH, I am only retiring from the official job of research at NIH, but I don't think I will ever be able to retire from SMS. So I will still be part of your community and available to families.
Thank you so much for that, Anne. And thank you for this amazing resource for our community. This was such a wonderful session. We appreciate you so much. I hope everyone enjoyed this evening's presentation on the history of Smith-Magenis Syndrome with Anne Smith. And remember that all of our upcoming webinars, as well as a list of our future webinars, and recordings of past webinars can be found on the PRISMS website under the Education tab. And also, please be on the lookout for an email with a link for me to a survey. Please take some time to fill out the survey if you can, because we'd love to know how we did. I hope that you all will join us on future PRISMS webinars. Make sure to like us on Facebook and join PRISMS. If you haven't already joined PRISMS, membership is free, and it's the best way to stay up to date with all things SMS. PRISMS is a nonprofit organization. All of our programs are funded by our generous donors, including this webinar series. So if you're interested in supporting PRISMS and the programs that it provides families impacted by Smith-Magenis Syndrome, please visit our website, prisms.org, and consider making a donation. So this concludes our webinar for this evening. I hope everyone enjoyed it, and I hope you have a great evening and good night.
Thank you, and good night.
Thank you. website, prisms.org, and consider making a donation. So this concludes our webinar for this evening. I hope everyone enjoyed it, and I hope you have a great evening and good night.
Thank you and good night.
Thank you.